All right, I think we can go ahead and get started. We have quite a few people who have joined already, and I know some more who will be joining. Welcome everyone to Geriatric Medicine Grand Rounds. Happy March. Hard to believe it's March. But we have wonderful speakers today. I just have a quick announcement before we start. For the faculty in our division, we will have our annual promotion meeting at 9 o'clock on a different Zoom link. So those of you joining for that, if we happen to be running over with questions, please leave this Zoom meeting and go to the other one so that we can start that one on time at 9 o'clock. But for everyone else, welcome to Geriatric Medicine Grand Rounds. Our speakers today are both physical therapists with the VA Puget Sound. Catherine Rice is a physical therapist based at the Seattle VA, and many of you who work in the VA have worked with her. And Maureen Wilson is a physical therapist based at the American Lake VA. And I just found out that they are the only pelvic floor physical therapists for VA Puget Sound, which is just impressive and amazing. And I'm very grateful, as I said, that you're taking time out of what I'm sure is a very busy practice to teach us today about fecal incontinence and some geriatric considerations in physical therapy. So I'll let you take it over from here, but thanks so much for joining us.
Yeah, thank you for having us. We're really excited to talk to you all today about this. I think this is something that we think is really important to be discussed kind of in an interdisciplinary manner, because this is really kind of a team sport, and hopefully we can see that as we go through our presentation. So let's talk about our objectives. So what we're hoping to cover today is describing what fecal incontinence is, the prevalence and risk factors, how to screen for fecal incontinence, conservative management, the role that we play in the treatment of fecal incontinence, and then how to get your patients to us, or if you don't work at the VA, how to kind of find our colleagues out in the private sector. So with that, we'll get started. So let's talk about what fecal incontinence is. The basic definition is really the unintentional passage of stool, solid or liquid. And a really important thing to consider is that this can coexist with diarrhea or constipation. I think a lot of people think about loose stool as being a part of fecal incontinence, but oftentimes in the geriatric population, what you will find is that fecal incontinence is happening in the setting of constipation. And we'll talk about this a little bit later in the presentation. The other co-occurring symptoms are oftentimes urinary incontinence. So most often what you'll see is a combination of both fecal and urinary incontinence happening together, as opposed to just fecal incontinence alone. The Rome 4 criteria doesn't have a distinction for the presumed etiology to make the diagnosis. But for research purposes, they define fecal incontinence as having at least 2 episodes in a 4-week period. There's different types of fecal incontinence. So you can have passive incontinence, which is the passage of either stool or gas without awareness that it has happened. Urge incontinence is someone who is actively attempting to stop it from happening, but they are unable, there's a discharge of contents. They're unable to retain those contents despite that attempt. And then fecal seepage. So oftentimes this is where someone has had otherwise normal bowel movement, and there's unintentional passage of stool following that normal bowel movement. And that really shows up oftentimes in the presence of dyssynergia and impaired rectal sensation. So let's talk about prevalence. One of the reasons we're excited to speak with you all is we see an increase in prevalence with increased age. Up to 15% of people over the age 70 are diagnosed with fecal incontinence. And oftentimes there's an increase in prevalence of fecal incontinence in persons who have been hospitalized, as well as persons who are institutionalized. In fact, there are a few studies out there that have found that up to half of institutionalized residents do have fecal incontinence. I think it's great to talk about the anatomy, to think through how, as physical therapists, we play a role in this. And just to orient you to this picture, so those two yellow structures are bones, and that white structure in between is the pubic symphysis. And that pink piece there is our puborectal muscle that kind of slings around the distal portion of the colon and helps to create that that colorectal angle to help maintain continence. So in healthy individuals, you get both the puborectalis and the external anal sphincter that are voluntarily contracted to stop defecation, or they're relaxed to allow for defecation. And what studies have found is as people age, there can be several related neuromuscular changes that can predispose people to fecal incontinence. So they'll see decreased anal resting and squeeze pressures, a decrease in rectal compliance, a decrease in the rectal sensation, and also an increased threshold to sense volume. So if we think about some of the lifestyle risk factors that show up for impacting that anatomic function, there have been some studies that connect obesity to fecal incontinence. Oftentimes what the studies have shown, though, is there is an increased risk for liquid fecal incontinence, but not solid. The current thought that was showing up in the research is that may be more linked to physical activity than actual body mass index. Smoking can play a role in an increased risk factor for fecal incontinence, and physical activity. So it's an association of a 25% increased risk of new fecal incontinence with decreased physical activity. Some studies out there that it's very little research. This is probably not the strongest research that we have. This shows that there can be some increased risk of fecal incontinence with anal intercourse, and then dietary factors. So this is actually a really big one. So decreased fiber intake can impact the risk factors for fecal incontinence. Also, what we find is there are medical comorbidities that can impact a person's risk for fecal incontinence. So we'll often find increased prevalence of fecal incontinence in persons with diabetes, with neurological disorders such as stroke, MS, and also inflammatory bowel diseases. So what the research was showing is that 10 to 15% of new cases of inflammatory bowel disease are often diagnosed after the age of 60. And about a quarter of those patients with inflammatory bowel disease often experience fecal incontinence. Ulcerative colitis is another condition that oftentimes has increased fecal incontinence as a symptom, as well as celiac disease, irritable bowel syndrome. And then finally, what can often show up as well is with cognitive impairments or dementia. Sometimes you can also see an increase in incidence of fecal incontinence. Like I mentioned before, one of the things that people oftentimes miss when they come through our door is the impact of constipation on their risk for fecal incontinence. And what can happen is you can get a fecal retention and fecal impaction that can disrupt the internal anal sphincter tone. And the stool can then leak around that impaction and then lead to fecal incontinence. So let's talk about the ramifications of fecal incontinence. Studies have shown that there is an increased rate of nursing home admission with persons who have fecal incontinence. It's one of the key factors that impacts a person's decision to go into an assisted living or nursing home placement, either the person or their family members who are supporting them. It can cause an increased risk for falls. So if I'm rushing to the bathroom because I don't want to have leakage, that can impact or that can put them at a greater risk for maybe moving without their assistive device or moving in a manner that puts them at risk for falls. We have the social aspects of it. So these are often can impact a person's willingness to go out into public, can decrease how much they're willing to be active because they're fearful of having an accident. This can disrupt sleep, which then can impact other aspects of their quality of life. There's the financial cost of incontinence care supplies. We're fortunate in the VA system in that we can order supplies to help support the veterans that we treat, but that's not always the case. And there can be a large financial cost for purchasing supplies to help address fecal incontinence. And then skin breakdown. So if we have someone who has that fecal material against their skin, that can cause skin breakdown and impact the quality of their tissues. This is one of the main reasons we wanted to talk to you all is because this is really a team sport. So we see a lot of people come through our clinics with these symptoms, but it really starts with the primary care and the providers that the patients are interacting with to start to have this conversation. Interdisciplinary care is really important. I would say oftentimes we may be addressing the neuromuscular or musculoskeletal elements of this, but there may be other elements that are contributing to the onset of their symptoms that are best done in coordination with their provider and maybe social work if there's a psychosocial aspect to it, or even our colleagues in mental health. So just know that this is oftentimes a condition that's best treated in a team setting. Despite the high prevalence that we see, research has consistently shown that only a very few number of patients will discuss fecal incontinence with their providers. What they found is among those who do discuss fecal incontinence with their providers, oftentimes they say that they were the one to bring it up. So I think this is a really important piece to say that it's asking patients about this and asking them in a very specific way is a really important place to start in terms of identifying patients who have these conditions so we can get them treated and back to functioning. The other thing is oftentimes what we find is there is kind of a sense of, oh, I'm getting older, ergo this is just a portion of getting older, and so I just need to kind of learn to live with this. And so there's oftentimes a false belief that this is just a part of aging, and so education can be a really important piece to discussing this. So words matter. Research has shown that health literacy really impacts how these conversations go. There are patients who may not realize what their symptoms are as fecal incontinence. They may simply label it as diarrhea. And there are some studies that say that there is preference to the language that is used, like an accidental bowel leakage. And this suggested language that we've consistently seen is something along the lines of, do you leak stool or do you have difficulty controlling your bowel movements? Right now, there's not a validated questionnaire used for screening for fecal incontinence in primary care like there is with urinary incontinence. And so across both the American GI Society as well as their Canadian counterparts. The language is slightly different, but the general request is, or the general suggested language is, do you leak stool or have difficulties controlling your bowel movements? And with that, I'm going to turn it over to Katie to kind of talk about how to take a subjective history and go from there.
Yeah, just to reiterate, a lot of veterans and patients won't bring this up unless asked. So we find it's really important to ask an extensive history about bowel habits. And this will help us to understand a little bit more about what's happening from a greater picture. Again, is this kind of more of a constipation issue? Are they having regular bowel movements, but then with that seepage? Are they having, or are they having true, or are they having urge incontinence, et cetera? So when we ask about the bowel movements, it's important to ask about frequency of bowel movements, whether they're needing to push or strain, if they're having any pain with bowel movements, et cetera. We use the Bristol stool scale, which is up there on the left, using a scale from 1 to 7. Actually, this picture has 8 in it, but the far left top picture is number 1, that's separate hard lumps. Number 2, lumpy sausage like stool. 3 is like a still sausage-like, but with cracks. 4 being smooth and sausage-like, like a snake. 5 soft blobs and edges, mushy. 6 mushy, ragged edges, and then 7 liquid without any solid at all. And then I'm guessing the last one is just like liquid for this particular picture. And this is really helpful. Type 1 through 3 is often considered kind of more of a constipation type stool. So if you're seeing someone with like low frequency or just the lumpy stools, and they're still having this fecal incontinence, that might indicate that actually constipation is a little bit more likely the direction that you want to go with your clinical decision making. And it's also, when we're talking about the FI symptoms, it's important to ask about onset. When did this start? How long has it been going on? Does it seem to be triggered by something? Medication changes, lifestyle changes, a particular food that they're eating, or is it just kind of ongoing? How often is it happening? When is it happening? At night? Is it happening during the day? Is it happening after a bowel movement? Again, this just gives us a really good clinical picture as to how we would direct our treatments. The volume, are they just having small amounts, or is it a full loss? Presence of blood is really important, especially checking those red flags. So we'll talk about those in a moment. And then the pattern, are they mostly having a loss of gas without wanting to? Is it liquid or is it solid? And again, that gives us some information about the anorectal sensation, muscle strength, some of that rectal compliance as well. And then it's really important to kind of consider vision loss, difficulty with communication, any gross or fine motor impairments. We're really looking from a PT perspective is, can they feel their bowel movements? Can they get to the bathroom in time? Can they get their clothing off in time? Can they communicate potentially with their caregiver if they need to get help to the bathroom if needed? So all of these considerations, we're not just looking as pelvic floor physical therapists at their pelvic floor, but also throughout. And these can also help you all in kind of identifying what the problems might be. So for medication considerations, FI can definitely come on with any changes. So new, recent antibiotics, herbal supplements, any changes in dosing, side effects, any drug-drug interactions, and then knowing that metformin can aggravate diarrhea. The recommendations in the literature for a medical provider is checking the abdomen for masses, any inspection of the perineum for breakdown and infection, testing the S2 through S4 nerve roots to make sure that, I know in PT school anyway, we learned S2 through S4 keep pee and poop off the floor. So we're making sure that the neuromuscular elements there are intact. And then anal wink testing, which is just a brush stroke to the side of the anus. And then getting looking for the anal motor activity of that anal wink with that, a digital rectal exam, and then considering any cognitive and functional limitations. And then blood tests can be individualized to their larger medical picture. So the CBC, thyroid stimulating hormone, the hemoglobin to look at the diabetes, potential for diabetes, et cetera. And then also of note, the American College of Gastroenterology doesn't really recommend any further testing as a part of the initial assessment unless that patient is responding is not responding to conservative treatment. And in terms of red flags, further testing is always warranted with any unexplained weight loss associated with the new onset of FI or the symptoms of FI, blood in the stool, abdominal mass, neurological deficits, and significant changes. And then any FI that would be associated with a change in the frequency of the stool that could indicate a malignancy. And then what does conservative management look like? So conservative management is considered any dietary modification. This fiber intake for people 51 and older is currently, the recommended values are 21 grams per day for females and 30 grams a day for men. We often see low levels of fiber. I recently had a primary care appointment myself with my physician, and she mentioned to me that I wasn't aware of this, the colonoscopy age has now lowered. And I just asked her, oh, why did they do that? And she said, oh, because like 0% of, Americans actually eat the recommended fiber. That made me laugh. I don't know if her stats are quite on there, but this is certainly an issue for the aging population as well. Also, possible food triggers can happen: lactose, fructose, gluten, coffee, sorbitol. I recently had an older individual coming in with a lot of comorbidities, and he's talking a lot about fecal incontinence at night. He's sleeping, he's eating like a quart of ice cream before bed. He has dry mouth and chews like massive amounts of sugar-free gum at a time, so packs and packs and packs. And he does have some pelvic floor findings. We can certainly work on those. Maureen had mentioned some of the important elements of continence in terms of neuromuscular needs to retain continence in the pelvis, and often we also need good stool quality. And if the lactose is really aggravating and this massive amount of sorbitol is really irritating, he's going to have a much higher likelihood of this incontinence as well. Also, stool bulking agents can be very helpful. Something I always find, this is a point of education for people. When we're talking about that Bristol stool scale, so the small pellets to the liquidy stool, a lot of people think that if their stool is too liquid, that they shouldn't have any stool bulking or fiber. They think that means they have too much, and actually fiber can kind of work in both directions. So we're doing a lot of education about how fiber can bring more fluid to the stool, and it also can bring more bulk to the stool. So considering that person's medical conditions, obviously if they're having any restrictions or adhesions or anything that's blockages, that might not be recommended, but keeping the person's medical picture in mind, as long as stool bulking agents are okay, that is very important to maintain that quality of stool. And then bowel training. So when we look at bowel training, biofeedback and pelvic floor physical therapy in the literature stated is often underutilized. There's good evidence of effectiveness, and that should be, according to this particular researchers, should be pursued for patients who have at least some preserved voluntary sphincter contraction. And that will bring us to what is pelvic health physical therapy. So as physical therapists, our job is to be experts in movement and movement systems. We are evaluating the musculoskeletal and the neuromuscular aspects of pelvic floor dysfunction. And because the pelvis also has primary roles in treating in urinary function, can contribute to pelvic pain, including genital pain, etc., and also contributes to sexual function, we're often kind of asking and looking for things a little bit more backed up, not just at the incontinence level, but certainly if someone's main concern is incontinence, that's what we'd be primarily working with. We work with an interdisciplinary team, so it really helps to be working with you all as medical providers and getting this from a lot of angles. You can work a lot of times with people on this conservative management, and then sometimes we have the advantage of seeing them on a more regular basis and helping to kind of use behavioral strategies to implement some of the recommendations that you might be making about this conservative management. We use a biopsychosocial approach and then a trauma-informed approach to care. So in the general community, and then especially in the veteran community, we are taking into consideration a lot of the trauma, including PTSD and or military sexual trauma that they may have experienced in addressing these concerns. And we're really working on patient-centered goals. So, you know, we want them to feel a good quality of life and to feel that they can be demonstrate self-efficacy in managing their condition to the degree that they would like to. And then at least at the VA, we're doing both in person and via and telehealth visits. I can't necessarily speak for other places, but currently at the VA, we are doing that, and we can sometimes do combinations as well. And a visit to pelvic floor PT, pelvic health PT, will look actually a lot like, you know, the subjective that we covered before. So we are also individualizing our care and individualizing our approach to the person. So we're not just, you know, walking in, sticking some biofeedback leads on them and then asking them to contract and relax. We're getting an idea of where their symptoms might be coming from. You know, whether it's constipation based, whether it's the seepage with this dyssynergia, that we're going to treat the pelvic floor differently than someone with a very weak pelvic floor. We are looking at, you know, their mobility, their orthopedic considerations. If they're not able to make it to the bathroom quickly enough or undo their pants well enough, they don't have the fine motor control for that, that's also going to impact them. So we want to really take their whole person into consideration. Again, also just considering their trauma, et cetera, and that will really guide our care. We want people to know that coming into us is safe, and that we're not like going to make them do anything. We are, you know, taking their emotional needs into consideration as well. For the pelvic floor muscle exam, this is always optional, and it can give us a lot of really good information. Also, if someone does not decide to take part in a pelvic floor muscle exam, we can also do, like, you can also assess, have them kind of feel and assess their muscles externally over clothing. Some people actually do really well with talking through and kind of feeling and sensing that. There's and just getting a good idea. So this will really, you know, depend on the individual in terms of how much they can take part in and want to take part in. And it's also important that when we're examining these muscles, a couple things are taken into consideration. So I kind of describe it like if I'm rehabbing a shoulder, I can, you know, really clearly see that range of motion in their shoulder. For the pelvic floor, I can't really see that unless I'm looking at the perineum directly. So the muscles start at the pubic bone in the front, they trace to the tailbone in the back, they come out to either sits bones. If they're contracting that muscle and they're fully clothed, I actually shouldn't see any movement. So it's a harder muscle, a more difficult muscle to assess. And that's, again, why we're doing a lot of subjective and a lot of like kind of orienting people to their symptoms and what they might be feeling. It also is sometimes thought of tradition or more broadly that people with fecal incontinence have pelvic floor muscle weakness. And this is sometimes true. But when Maureen also kind of went through that other slide about the anatomical needs for continence, we need good anal rectal sensation. We need good muscle strength. We need good rectal compliance, neurologic integrity. We need that resting tone to be there. We also need muscles contract, they relax, and then they also, they contract, they relax, and then they descend and kind of come down towards our feet a little bit when we're pushing to have a bowel movement. So if that coordination isn't very good, then that can affect their symptoms. If also people who experience fecal incontinence often are so nervous about that fecal incontinence or so aware of it that they're constantly holding their muscles very tightly. And then those very tight muscles become overactive or less functional. So a muscle that's already fairly tight just doesn't have anywhere else to go to help to support them. Also, if you think about kind of like, you know, your shoulders, if you're someone who like holds tension in their shoulders, that those muscles can get kind of tight and tender. You might need like a little massage to let those relax a little bit and get those moving a little bit. The same thing happens in the pelvic floor. If you're someone who holds their muscles very tightly all the time, they're gonna kind of be tight and tender and irritated. So we can work on just normalizing that muscle function. And that is something that we can find through that exam. And again, often through the subjective and just kind of talking with people about this. Again, just really specifically in the geriatric population, we're really looking at this mobility, fine motor, gross motor, and cognition and caregiver support. So someone who is 40, fully mobile, no cognitive conditions or concerns, we're going to really address their concerns, different than someone who might be in their 80s having, some cognitive concerns, and caregiver support can be a really important aspect in this geriatric population. Someone who is able to remind someone who might need reminding about, going to the bathroom, or supporting them to get to the bathroom, or bringing them foods that support their bowel health. All of this plays a considerable role in, their ability to succeed in managing this well. In terms of intervention, so again, on this conservative management, we're actually doing a lot of what's recommended in the literature for conservative management that medical providers are doing. So educating on what is normal, maybe doing some bowel bladder diaries to get an idea of what's happening, doing some dietary and fluid education, and helping to find out whether what their toileting position is and whether they have the ability to kind of adjust this to maximize their bowel health. We do therapeutic exercise. So again, this might help to get them more mobile, to make it to the restroom, or even just to be able to achieve a really good toileting position for them. So a lot of these people might have other comorbidities, other weaknesses, back pain, et cetera, that kind of makes them unable to get into this position or to achieve what they need to do to maintain continence. And then we look at exercise specific to the pelvic floor. And I'll go over biofeedback in a moment, but again, we're looking at, does this person need strength? Do they need coordination? Do they need just some awareness? And how can we help them manage, the condition that they have? And this brings us to, I wanted to highlight toileting positioning because this can be really helpful and actually kind of there's a lot of bang for your buck, I guess, with this type of care. So Maureen had showed the picture on the bottom, kind of left picture, about that anal rectal angle that's need to maintain continence. And again, just reiterating that we also need that compliance of the rectum and the normalized anorectal sensation. So someone might have decreased or increased rectal capacity or sensation, but that muscular control of the puborectalis and the extraanal sphincter will help us to maintain continence. This angle happens most often when your hips are above your knees. So if someone's sitting on a toilet with their hip above their knees, then they're more likely to have this little kink in their colon. And when you then bring your knees above your hips, so more of a squat position, the puborectalis lengthens, basically, which allows the colon to straighten out. And that allows for a more even passage of that stool. So one thing that we often see in the geriatric population is that to optimize for mobility and ease of sit and standing, we're getting these higher toilet seats. But unfortunately, that might be decreasing their ability to have a easy and bowel movement. It can potentially increase their likelihood of constipation, which we have reviewed as also, potentially problematic for their fecal incontinence. So this can be one of the things that we manage. So getting some toileting positions at the VA, we're able to order squatty potties, which is fantastic. They're also fairly inexpensive and helpful for people to get their knees up. In the geriatric population, though, we also need to consider mobility. Do they have any recent total hip arthroplasty restrictions? Is this even comfortable for them to be in? If their knees are up above, their hips now, but this isn't a comfortable position, they're also not going to be able to relax those muscles to have a good bowel movement. So there's a lot to consider, but also toileting position can be something that is like a great education piece for this population. And then we wanted to touch on biofeedback because this is one of the primary, I would say, in the literature, it's the most talked about piece, and what's probably as physical therapists we get the most questions about. So we like to highlight that it's really part of the treatment plan. Prior to initiating any sort of biofeedback, we're still doing a lot of education, normal defecation physiology, posture, breathing techniques, pelvic floor function. Some people can get a lot out of care without the additional need for biofeedback. Or the technology aspect of biofeedback. We can also perform biofeedback in other ways without the equipment. But because biofeedback is really just this behavioral learning process, right, that relies on visual, auditory, verbal, even tactile feedback, in this proprioceptive feedback, using this equipment, we are able to do that, highlight that like in the use of some visual feedback through the use of the this computer screen. So the top left picture is an example of a biofeedback equipment that we might use. And in this treatment, you either place on the bottom left corner the SEMG, the surface electrode, EMG electrodes that we would use. They're actually, they're just like pediatric cardiac electrodes. They're very, very small. We place them on either side of the anus, and then also a grounding electrode. Or you can use an internal electrode, which is on the top right corner, where you're placing that electrode either rectally, or for women, sometimes we'll do a vaginal electrode for people with vaginas. So then we're able to sense, like, all this is doing is measuring the electrical output of the musculature in the pelvic floor. So you're able to see on this screen like the normal muscle function, and then when they contract, you should be able to see a rise, and then when they relax, a decrease. You can also place abdominal electrodes to see like what the abdominal pelvic floor coordination is like. So that's really helpful, especially in dyssynergia. And it should be known that this really requires a lot of active engagement. So they need to have good enough cognition to participate, and also be really motivated. Like, this needs to be interesting and meaningful for them to be helpful. It's not a passive modality, and we will individualize this to this person's impairment. So also, like I mentioned, it can be helpful to like isolate these muscles, strengthen them. Also, for people who have overly tight muscles, sometimes it can be helpful to help them to learn to relax them, to help with that coordination for bowel movements. And the bottom right picture is a picture of a deflated rectal balloon that we can use. We can insert this rectally and then blow it up, and just millimeter by millimeter. And what that allows for is testing whether their compliance of their rectum is in normal limits. And if not, if it's hyposensitive, we can help to normalize we can blow up the balloon slowly and have them get used to that sensation, doing contractions, and kind of modulate that rectal sensation. If it's hyperactive, like hypo or hyper, either way, we inflate the balloon and then have them do contractions, so that if it's hypo, they can sense the rectal sensation sooner, and if it's hyper, that they can put off or decrease that sensitivity with the balloon present. So that's biofeedback. And then we did want to talk a little bit about referral to pelvic floor PT. This is just important in the sense that a lot of people will come into our offices not at all understanding why they might be coming to physical therapy for fecal incontinence. And so, talking to them about the referral, why they're being referred, that there are muscles in the pelvis that help us with these with this condition, that there can be something done, that a lot of times this can be made a lot better, if not completely resolved, again, depending on the severity, but a lot of people do great with PT. And then it can also be helpful to tell people that this can involve a vaginal or a rectal muscle assessment, just so that they know and are completely caught off guard, but also that it's not a requirement. So if this is going to be a barrier for them coming in, there's certainly a lot of care that we can do that that doesn't involve this. And a lot of people also find that once they come in, have a few visits with us, and then if we, they also might find that they're more comfortable at some point. However, we're always using a trauma-informed approach and really doing patient-led care. I know a lot of you are not at the VA, potentially other systems, but we do just like to do a little how to refer to us if you are at the VA. If you go to outpatient consults, physical therapy, pelvic floor, right there. Where do they want to receive care? Seattle will come to me, American Lake will go to Maureen. And then if you can hit this unless they happen to be perinatal, then the general pelvic health PT is a great one to hit. And then the reason for referral, any precautions that they might have. And then that'll bring you to the next screen, which is putting in the diagnosis, et cetera. And we were happy to see your people. If you're someone who's not at the VA, I know Dr. Bennett had mentioned that there are people here potentially from University of Washington. There are excellent PTs at the University of Washington. I used to work there and have colleagues, old colleagues there, also who are incredible, top of their field. There are also excellent providers at Swedish. I don't remember exactly who's currently there, but I know of some previously. So, and then out in the community is also somewhere that if you can find pelvic floor PTs who also do bowel care, excellent option. And here are our resources. And then 43, okay, we're on time here. So any, Dr. Bennett wanted you to fill out this evaluation for us, and then we're happy to answer any questions you might have.
Great, thanks so much for that presentation. That was really helpful. We have one question already in the chat from Amy Thomas, and she was just wondering if you could comment on recommended supplies that are best for fecal incontinence. In particular, that she had read someplace that tabbed undergarments were better than pull-ups, and wondered if you agreed or feel that's accurate.
Yeah, I think in certain cases that can be a benefit. I think it depends on the person who you're treating and what their particular mobility needs are. Sometimes it's nice to be able to have that removal. Sometimes getting the tab briefs or the tab undergarments can be a little bit difficult. So another version of this, some of the brief style ones have a rip away side function that gives you like a tab function. And so that can sometimes give you the same benefit of being able to quickly remove a garment that has been soiled and replace it without having to completely disrobe. So yes, the tabs can be important for some people with mobility impairments. Just know that the traditional, like ours are blue with a white tab, sometimes getting those up and in the right place can be a little bit of a challenge. And so the undergarments that are more like briefs with the sides that can either be torn away or can be, it's almost like they have a Velcro. It's not quite Velcro, but it's a side that you can pull apart and put back together. That can be, give you the best of both worlds, where it's an easy garment to kind of pull on and maintain in place, but then you can tear away the sides once it's soiled.
Great, thank you. There's another question that came in, and the question is, do rectal polyps exacerbate fecal incontinence? And if so, is there anything that can be done about it?
This is a great question. I actually am not sure about the polyps. Do you know, Maureen? What I will say is that I could take a moment and look that up. I apologize, I don't have the answer for you directly. what I will say is that I tend to see a lot of people who come in and attribute their symptoms to something medical that a medical diagnosis that they've received, and there's still muscle dysfunction or dietary considerations in the context of their medical condition that can be contributing to their symptoms. So they might be, so I often am taking the approach of, okay, you're adhering to your medical care around a particular medical condition, the recommendations that the provider, the specialist has given you. We're looking at any additional changes to your behavior that can be done, right? Like any positioning, diet management, et cetera, that is still within the context and safe within the polyps or safe within the medical condition. And then looking at the muscle function on top of that. So I would say it's definitely dependent on the person, but I think a lot of times this muscular function is overlooked and maybe could potentially be inappropriately blamed, so to speak, and I think sometimes too, like I often talk to my patients about how like their symptoms might be a pie, right? So like, or like represented in a pie. So it could be that 25% of this person's symptoms is kind of due to some diet, stool concerns that are making it difficult for the rectum to sense the stool, or we want to normalize that. And maybe this person, just 25% is muscle dysfunction, and maybe 25% is this medical condition that we're going to have a harder time making any change for. But like even with that pie, I don't know what the other 25% is. We'll figure that out. But in this instance, even if 50% of those are kind of able to be managed better, their quality of life may be a lot better. So I think something else we didn't really speak to is that I find that people with fecal incontinence are just distressed often, not always, often. And sometimes I have people come to me that are like, 6 months ago, I had one episode, and they are incredibly distressed by this one episode, and they are just in my clinic to make sure that never happens to them again. And then other people, are having this day after day after day, and they also are distressed potentially or often. But like I think the one thing to know is that the one thing to consider is just even sometimes this one episode can lead to a lot of the ramifications that Maureen covered, the social isolation, not wanting to go out, especially in geriatrics. They're like really concerned and using their community to stay healthy mentally. Like they want to go out and meet friends and be with people and stay engaged often. And this fecal incontinence can be, even if it only happened once or twice, can be the thing that really disrupted that. So anyway, that's a little bit of a side, but I'd wanted to cover that and didn't.
That's all really important. Thank you. There's a comment from one of the VA faculty saying that first of all, thank you for your presentation and the resource, and are glad to have you as a resource at the VA. But they're wondering, for those of the folks on the call who are at the VA, is it helpful for them to Teams reach you about referrals or potential referrals?
Yeah, definitely. We'd love to hear from you all and reach out. If you have a question, feel free to reach out to us through Teams. We both have busy clinics, so if we don't respond back immediately, or we might say like, hey, I'm with a patient, can I get back to you in an hour or so? But yeah, we definitely want to collaborate with you all about your patients, and if you have any questions.
Yeah, and also like it's great to ask us about whether you think this would be a good person to see. We're happy to do a lot of like pre-consult chatting, and also like if we get someone to us and we don't feel like they're appropriate or would be appropriate but need some additional management prior to, we do like to that we appreciate that interdisciplinary care, and we'll send them back to you if we have concerns, and then make sure we can get them in again when those concerns are addressed. So we like back and forth and chatting, and are happy to be a resource. That's what we're here for. Thank you for having us. Yeah, are there any other questions?
I did have one question. You mentioned how helpful the squatty potty is, to get patients in the right position. But I'm just wondering how you select patients that are appropriate for that, because we're always worried about falls and hazards in the bathroom. And I'm just wondering how you choose the correct patients for that, and any strategies you have for making that as safe as possible when we do have concerns about, tripping or getting off and on the toilet safely.
It's a great question. I mean, one cool thing about the squatty potty is that it actually pushes underneath the toilet. So that's why the little divot is there. So I have found that as long as someone has the cognitive ability to push it under and manage that, and then also the mobility and cognitive mobility and or help to then pull it out, and safely, like we would do an evaluation to make sure that they can safely sit, they can safely place their feet, safely place their feet. So we have one in the clinic that I just have sitting around. And if you find that it might be something great to have in your clinic, just to, you can even use the table, your treatment table, if it goes down to a level, and then kind of evaluate whether they're able to sit down and place their feet and the level of balance that they might need for that. I think that can give you a fairly good idea. But yeah, I find that is crucial. Anything else you would add to that, Maureen?
Yeah, I mean, I think the other piece is I actually can't think of a single time that I've issued it without also issuing some really specific toileting instructions. So it's a piece of a larger plan. So it's not just like, here's your door prize for coming to PT, squatty potty for you and squatty potty for you. That more it's looking at the whole picture. And so we may be working on connecting that with breathing techniques and positioning techniques, and kind of putting that as a whole. It's just one piece of a larger treatment plan. And I mock up toilets in the clinic. So I'll raise my toilet, not my toilet. I don't have one of those in my clinic, but I'll raise my treatment table to the height of their toilet and say, okay, is this what this looks like? Okay, let's put the squatty potty here. How does this feel? Someone might say, well, I have a very narrow space, or I have a bigger space. And so I might be simulating those things in the clinic and then working on those skills within the clinic. I think that's one of the benefits that we have in clinic, is that we have more time with our patients to really sit down and say, walk me through exactly what your environment is like, and then walk me, let's come up with solutions and let's practice those solutions, and then setting up a treatment plan and a home exercise program that may not look like 3 sets of 10, but may look like practicing these skills to help them learn those techniques. So I would say, yes, a squatty potty, you have to consider like fall risk and mobility, but I think when you see that it's a part of a larger active treatment plan, I am less concerned about those things, because we're looking at the person holistically.
Fantastic. Thanks so much. And thanks to both of you for a wonderful presentation and for answering our questions, taking the time with us today. Please, everyone, fill out the evaluation and share how much you appreciate this talk. Again, reminder for faculty, please head over to the other Zoom link for our faculty meeting for the folks who have to join that. And thanks again, everyone, for joining us. And again, thanks for our speakers. Really appreciate it. Have a great weekend.
Have a great weekend. Thank you.